Okay, we're going to go ahead and get started. Great session. Definitely great words that were spoken that we all need to keep in mind as scientists and researchers. So we're going to change the topic to pancreatic cancer. My name is Antonio Baines. I'll be one of the speakers after the speaker that's about to come forward. I'm going to give a little small introduction. So our speaker next, his name is Dr. Douglas Fearon. He's an MD. He received his MD from Johns Hopkins Medical School and has been a professor of medicine at Harvard Medical School, Johns Hopkins, and the University of Cambridge, where he was also the Sheila Jones Smith Professor of Immunology. He currently is the Walter B. Winston Professor of Pancreatic Cancer Research at Weill Cornell Medicine and Professor at Cold Spring Harbor Laboratories. He has done research in various areas, including complement systems, memory, CD8, Tcell development, and most recently, tumor immunology. Let's give a hand to Dr. Fearon.
Thank you for inviting me here to participate in your symposium. It's difficult to follow with the cold science a compassionate, sensitive discussion of a past medical injustice. And as I was sitting listening to this, and I had some association since I went to Johns Hopkins Medical School and did my internship and residency there, I was reminded of an experience that I had as an undergraduate in college. And we had Martin Luther King to speak at our chapel. And I felt that I had many privileges in life and had some sense of guilt about that. And I always remember his discussion of saying, well, convert that guilt into a responsibility to make the most of your advantages. And none of us can ever do that, but Mr. Carter certainly has contributed more than most of us. I'm going to be talking about a chemokine receptor called CXCR4. And I'm going to present to you not the preclinical work that led to us focusing on this, but I'm going to present the results of a phase 1 clinical trial. The preclinical work in mice is interesting, and it led to the rationale to doing the experiment in humans, but it is the experiment in humans that all of us are interested in. So I'll focus on that. I disclose that I'm a co-founder of a LLC based on a patent that University of Cambridge filed based on our work, and I'm on the SAB of a biotech company called iTeos. I'll obviously talk about the clinical application of our discovery in mice and pancreatic cancer in Cambridge, but I don't think I'm going to benefit financially from this work, but that's not why we go into research. Okay, the 5-year survival of pancreatic cancer is between 5 and 7%. It's not shown any improvement despite other cancers showing marked improvement in survival. African Americans have a 25% increased incidence in pancreatic cancer. Perhaps it's related to what the previous speakers had talked about. Obesity does predispose to pancreatic cancer. But regardless of your race, this is not a good disease to have. So how is immunotherapy faring in pancreatic cancer? You've probably heard that immunotherapy is being proven of great benefit to a subset of patients with a subset of cancers, melanoma, non-small cell lung cancer, smokers, some patients with renal cell carcinoma. But pancreatic cancer, in a trial published in 2012 of anti-PD-L1, the PD1 checkpoint, no pancreatic cancer patients responded, and none have in any trial subsequently. So pancreatic cancer has been resisting immunotherapy. Is it a cancer that we will not be able to modify the course of with immunotherapy, or have we simply not been doing it the right way? Have we not discovered the immune suppressive pathways that operate in pancreatic cancer as compared to, say, melanoma? So that was a question that we started out to pursue back in about 2012, around the time of this publication. We had discovered an immune suppressive pathway 2 years earlier, and we decided to say, is it operating in pancreatic cancer? Now, this is a PD1 checkpoint. I just put it up briefly to say why I think it's not working in pancreatic cancer. The tumor cell expresses an antigen that T cells can recognize, because T cells, clones of T cells, will have T cell receptors that recognize that peptide located in the groove of the MHC class I membrane protein on a cancer cell. The cancer cells and other normal epithelial cells protect themselves from immune attack by upregulating a membrane protein called PD-L1. And PD-L1 can engage a receptor on the T cell called PD1. And when PD1 is engaged, it turns off T cell receptor signaling. So a therapy designed to inhibit this suppressive pathway is either antibodies directed to PD-L1 or PD1, preventing that interaction. But you can see that this PD1, PD-L1 inhibition will only work if T cells are encountering cancer cells. If the T cells can't even get into the cancer, then antibodies to PD1, PD-L1 will be ineffective. So do T cells get in the cancer cell nest of pancreatic cancer? They do not. These are tissue microarrays of biopsies of pancreatic cancer, and the cancer cells are in red, and the T cells are in this white greenish color. And you can see the T cells are actually in between the cancer cell nests. They're in the cancer stroma. They're not coming in contact with the cancer cells. So 5 of the 6 biopsies show that phenomenon. This biopsy shows that T cells can get in to cancer cell nests, but this patient has microsatellite instability, MSH high, it's very immunogenic, and having a lot of antigens that the immune system can recognize overcomes this block for T cells getting into the cancer. But we cannot make these cancers more immunogenic. So we have to discover whether or not there is a process that excludes T cells. There is a paper published 2000 from investigators at the Massachusetts General Hospital. Active movement of T cells away from a chemokine. The chemokine at that time was named SDF1. It is CXL12. And you can anticipate that CXL12 is the ligand for CXCR4. There was selective repulsion of subpopulations of T cells at high concentrations of recombinant SCF1 or CXL12. So in the chemokine instead of attracting T cells, which express CXCR4, actually repel them. Well, given that, isn't it interesting that the pancreatic cancer cells are coated with this chemokine, CXCL12? This is a mouse model of pancreatic cancer. It's a so-called KPC model that Dave Tuvison developed. And the stains are with anti-CXL12 in red, anti-cytokeratin 19 identified in the cancer cells. This is a merge. This is just showing the CXL12 staining and the CXL12 monoclonal antibody staining in cancer cells. We can see the same thing in human pancreatic cancer. These are serial sections of human pancreatic cancer. Here the green stain is anti-CXL12. The cancer cells are staining green. The T cells in red are excluded from the cancer cell nest. And here is this cytokeratin 19 antibody simply identifying that these are the cancer cells. This phenomenon is not restricted to pancreatic cancer. It occurs in a mouse model of non-small cell lung cancer. The cancer cells are coated with the green anti-CXL12 antibody. Red CXL12 antibody, CK19 is in green. And human pancreatic cancer is stained with monoclonal anti-CXL12. Human ovarian cancer, prostate cancer, colorectal cancer, and we've even found examples where normal epithelial cells take up CXCL12. So we have a situation where we don't even we did not know the mechanism by which cancer cells capture CXCL12. They're not making it. Fibroblastic cells in the stroma are making this chemokine, and we've recently discovered how the cancer cells take it up, but we didn't need to know that mechanism to wonder whether or not this is important and accounts for why T cells are excluded from the cancer cell nest, why pancreatic cancer escapes from immune control. So what I'm trying to say that we envision happening is cancer cells have an ability to capture CXCL12 in blue, then the T cell and other immune cells come in, their receptor for CXCL12, CXCR4, signals the cell, and it migrates away. So, there was a small molecule developed to inhibit CXCR4 back when there was not yet efficacious treatment for HIV. CXCR4, the receptor for CXCL12, is a co-receptor for HIV. And one of the drugs developed to block HIV binding to CXCR4 is this molecule called AMD 3100. It interacts between the extracellular domains of the receptor and blocks not only HIV binding, but it was discovered to block CXCL12 binding. It's clinically approved to release hematopoietic stem cell from the bone marrow. In our preclinical studies, we gave this molecule continuously by osmotic pump to mice with pancreatic cancer, KPC mice, and the immune system stopped the growth of the tumor, and the tumor became sensitive to a neutralizing antibody to PD1. That was in mouse system. On the basis of those findings, we submitted an application in 2014 to Stand Up to Cancer and the Lustgarten Foundation to do a clinical trial. The clinical trial, we were only allowed by the company providing AMD 3100 for the trial to give it for 7 days. And this is obviously too short a period of therapy for immunotherapy. No other immunotherapy works in 7 days, clinically works. But we were hoping that we could obtain evidence that blocking CXCR4 in pancreatic cancer and colorectal cancer patients would heighten the immune reaction in biopsies of metastases. So we took core biopsies before the started infusion of AMD 3100 and at the end of 7 days, and then compared the biopsies, the paired biopsies, by analyzing the transcriptome. The expression of genes or expression of immune genes, are they influenced by giving AMD 3100. So this is an update that was provided to me by Daniele Biasi, a computational biologist in Cambridge. A trial was done in Cambridge, UK. And when we simply subjected the paired post versus pretreatment biopsies to pathway analysis, the top pathway that was enhanced was an immune pathway of allograft rejection. So we not only enhance the immune reaction, AMD 3100 not only enhanced the immune reaction in the tumor biopsies, but it was precisely the immune reaction that one would like, because allograft rejection, as you know, if you can treat cancer as an allograft, then the immune system will kill cancer. The other immune pathways are upregulated: inflammatory response, interferon gamma response, IL-2 STAT5 signaling, and a type 1 interferon response. That was colorectal cancer patients, and they had the same results in pancreatic cancer patients. So remember, I described to you, I only showed you coding of pancreatic cancer cells with CXCL12, but I told you colorectal cancer cells are also coded with CXCL12, and indeed treating either cancer by blocking CXCR4 improves the immune reaction in the tumor biopsies, precisely the immune reaction that an immunologist would be looking for. Now, we were limited to 1 week of therapy, and this was not enough to have a real clinical outcome. But what about, can we compare the changes in gene expression in the biopsies of patients treated with AMD 3100 to the changes in gene expression induced by anti-PD1 in melanoma patients, which does respond to anti-PD1? Do we induce the same changes? And these are the pathways that are the immune pathways induced in melanoma patients in their biopsies by treatment with anti-PD1 in collaboration with Tim Chen, who published his trial in Cell. So that gives us at least an opportunity to suggest that AMD, if given longer period of time, would have a clinical effect. What is happening to very specific components of the immune pathways in the cancer biopsies? So T-cell receptor genes are upregulated in colorectal cancer patients and pancreatic cancer patients, and in the trial of anti-PD1 at Sloan Kettering in melanoma patients. Granzymes and perforin are the proteins that reside in cytolytic granules of CD8 T cells that enable them to kill normally virally infected cells, but to kill cancer cells. We also found upregulation of granzymes and perforin in the colorectal cancer patients, the pancreatic cancer patients, with false discovery rates that are comparable to the upregulation of the expression of those genes in the melanoma patients treated with anti-PD1. Can I present additional evidence that might suggest that this enhanced immune response actually has a negative effect on the cancer? So Daniele investigated the expression of genes that would be characteristic of the cancer cells in the biopsy, only expressed by the cancer cells in the biopsies, and looked at the expression of those cancer cell genes in each of the individual colorectal cancer patients and correlated them with the upregulation of granzymes and perforin. So a downregulation of cancer cell gene expression correlates with upregulation of the genes encoding the effectors of CD8 T cell killing. We also found the same relationship in the pancreatic cancer patients. So again, inferential evidence to support the possibility that inhibiting CXCR4 will enable the immune system to kill cancer cells in colorectal and pancreatic cancer. If that is meaningful, another test would be to ask which pathways are inversely correlated with the expression of T-cell receptors in AMD 3100 treated colorectal cancer patients. So does upregulation of T-cell receptors, which we found in the patient's biopsies, what downregulated pathways does that upregulation correlate with? And for the most part, it's terms related to cell cycle. So we would consider the most likely cells in the biopsies that be cycling would be the cancer cells. Genes, so then Daniel A. did, I thought, an imaginative computational biology approach. There have been studies attempting to determine biomarkers that would identify melanoma patients that respond to anti-PD1 or anti-CTLA4 compared to those who will not respond. And so there have been 4 studies where RNA-seq has been done on paired biopsies of melanoma patients, pre-therapy, post-therapy, and then retrospectively saying, comparing the pre-therapy biopsies of the responders versus non-responders. And we find genes are upregulated in these 4 different studies: Van Allen, Oslander, Riaz, and Hugo. Those genes that are increase in expression in pre-treatment biopsies that predict response to anti-PD1 or anti-CTLA4 are the genes that are significantly upregulated by AMD 3100 in the pancreatic and colorectal cancer patients. That would be consistent with our preclinical mouse studies where we found inhibiting CXCR4 made the mouse pancreatic cancer sensitive now to anti-PD-L1, where without treatment it was not. So I'll close by saying this is obviously an interim report. We're planning a phase 2 trial of combination AMD 3100 plus anti-PD-1 immunotherapy with Liz Jaffe at Johns Hopkins and Brian Wolpin at Dana-Farber Cancer Institute. I've just shown you the clinical data of the phase 1 trial done in Cambridge. It was directed by Duncan Jodrell with these people in his lab. I've shown you the analysis of the data by Daniel A. Biasi, to whom I'm extraordinarily grateful. So thank you very much, and I'd be pleased to answer questions.